Good morning, everyone. I am Dr. Marwa Salah, lecturer of internal medicine and endocrinology, Faculty of Medicine, Alexandria University. And for today, my dear student, we are going to discuss the approach of a case of short stature. So let's start. First of all, we would like to know what is short stature or what is the definition of short stature. It means that the height of the child is below the third percentile, or the height of the child is more than 2 standard deviation below the median for age and gender for each child. So usually the patient is presented with the following, that he is complaining of he's too short compared to his colleagues or his peers of the same age, or that the child younger than this patient is taller than him, or as we mentioned before, that the height of the child is less than the third percentile for his age and gender. Before we go to talk about the causes of and etiology of short stature, we need to know about the normal factor that affecting the growth. And usually we divide these factors into endocrinological factors and non-endocrinal factors. So the non-endocrinal factors include the birth size of the child, the nutritional status of the child, the general well-being, the presence of psychosocial factors, and finally the endocrinal factors that include the hormones that are responsible for the growth, which are mainly the growth hormone and the thyroid hormones. So based on this physiology, we can divide or classify causes of short stature into physiological causes and pathological causes, where physiological causes include mainly familial and constitutional. And here where we start with physiological causes, because these are the most common causes of short stature. So you have to know that familial and constitutional delay of growth and puberty contribute for the major causes of short stature. On the other hand, pathological short stature includes malnutrition or undernutrition, which is the most common cause of short stature worldwide, followed by the presence of any chronic systemic diseases that we are going to explain later on. Endocrinal causes mainly growth hormone deficiency and hypothyroidism. As we mentioned before, the growth hormone and thyroid hormones are very important for the growth. So the presence of growth hormone deficiency, the presence of hypothyroidism contribute mainly for the main causes or endocrine causes of short stature. Other less causes, they are less common, so we are putting them in the end of the list, including psychosocial dwarfism, small for gestational age babies, skeletal dysplasia, and genetic syndromes. Here we are going to go through briefly through some of the causes of short stature, starting with malnutrition. As we mentioned before, it's very important. The presence of malnutrition or malabsorption lead to failure of thrive, which means that the patient or the child will have both short stature and underweight. So if you find or confront with a child affected his stature and the weight, you should ask the mother about the nutritional status of the child. The other example for pathological causes of short stature are the presence of chronic systemic disease. So you have to ask the patient or the parents, does the child treated or suffering from any chronic systemic illness? This includes cardiovascular diseases, including congenital heart disease, respiratory diseases, whether bronchial asthma, GIT disease is common in the children, including inflammatory bowel disease, celiac disease, liver cirrhosis, or collagenic infiltrative liver disorders, renal, in the presence of nephrotic or nephrotic syndromes, hematology. You have to ask the patient if he is treated from iron deficiency anemia or the presence of thalassemia or other chronic hemolytic anemias, the presence of chronic infection or abuse or neglection of the patient. So it's very important to search for these causes when you are confronted with a patient of short stature by taking a detailed history and appropriate physical examination. Next, we are going to speak about the two most common causes of short stature اللي هم physiologic causes that include first the familial short stature. Familial means there is positive family history of short stature in the family, and here we diagnose the patient by the following criteria. The patient usually has normal height and weight at birth, but later on he catch down growth. Although there is a normal growth velocity, however, by age of 2 years, the height and weight lies on the target centile, and after that, the patient remains in the below the normal third percentile for the normal population. The bone age of the patient is equal to the chronological age. There is no affection of the skeletal maturation. The patient attains normal puberty. However, the final height of this patient will be low, but within the target range for his family. The next common physiologic causes of short stature is constitutional delay of growth and puberty. Here the child is presented with normal length and weight at birth, with normal growth till the first year of life. However, later on, starting from the second, third years, there is deceleration and diminished growth velocity. So the patient lies below the third percentile, however, parallel to the third percentile, but below. So the patient will suffer from short stature. Usually, most of these patients will have delayed puberty, which means that the patient attaining puberty at a later age than his colleagues with the same age. So the patient, when you are confronted with a patient around the age of puberty, presented to you with delayed puberty and stunted growth or short stature with positive family history of delayed puberty in one or two of his parents, you should suspect constitutional delay of growth and puberty. This patient bone age is usually less than the chronological age due to deceleration of the bone growth velocity, while the bone age is equal to the height age, and the patient final height is normal. And we should mention that there is definitely a family history of delayed puberty in one of his parents. Through the next slides, we are going to show them some of the other less common causes of short stature, starting with genetic syndromes, including Down syndrome and Turner syndrome. Turner syndrome, this is a genetic syndrome characterized by the presence of karyotype 45X, so it's presented in females. The patient is presented with typical phenotypic or clinical features. This includes short stature, ovarian or gonadal dysgenesis, or the presence of ovarian streaks or gonadal streaks. The patient may have congenital lymphedema, short webbing of the neck, broad chest, wide separated nipples, cubitus valgus or wide carrying angle of the elbow deformity, and the patient may have congenital heart diseases in the form of aortic coarctation. This patient usually presented with short stature and primary amenorrhea. So when you are confronted with a patient, female patient, presented to you with short stature and primary amenorrhea due to the ovarian dysgenesis, you have to search for this clinical feature of Turner syndrome and ask for karyotype to confirm the diagnosis of Turner syndrome. When the karyotype reveals the presence of 45X, this means that the patient is suffering from Turner syndrome. The other genetic syndromes that are associated with short stature is skeletal dysplasia, or what is called achondroplasia. Achondroplasia is a genetic syndrome, autosomal dominant. It's characterized by loss of ossification of the cartilaginous joints that are present in the limbs, upper limbs and lower limbs. So the patient will have normal trunk, however, the affection particularly in the long bones of the arms and legs. So he will presented with short limb dwarfism, or what is called disproportionate short stature, normal trunk and short limbs with normal intelligence. So the clinical features characteristic of achondroplasia including disproportionate short stature, as you can see here in the picture. The patient has normal trunk, however, relatively large head with shortening of the arms and legs. The patient may present with frontal bossing or prominent forehead, megaloencephaly, or mid-face hypoplasia. Finally, the psychosocial dwarfism or psychosocial short stature. This means after exclusion of any organic disease, you have to ask about the psychiatric history of the patient. So patients suffering from psychiatric disorders including emotional deprivation syndrome or maternal deprivation syndrome or hyperphagic short stature, they common or may suffer from what is called functional hypopituitarism. In this patient, they have low levels of IGF-1 and inadequate response to growth hormones, so their growth or height may be affected. Later on, if you with less environmental condition and good psychotherapy, the patient catch up growth and attain normal height later on treatment. So finally, we can summarize the evaluation of short stature regarding the causes and etiology of short stature, and this includes detailed history from the patient or the parents. Regarding birth history, you have to ask the patient about the gestational weight, because we mentioned that small for gestational age is one of the causes of short stature, and birth weight is one of the common factors that affect the growth later on. The birth weight, the mode of delivery, the presence of any noted complications. Then nutritional history, including the appetite of the patient, the bowel habits, the pattern of growth, the presence of any malabsorptive disorders or vitamin deficiencies. The medical history, including you have to ask the patient if he is treated or suffer from any chronic systemic illness or diseases, including cardiovascular, respiratory, GI disease, as we mentioned before. The drug intake, it's very important to ask the patient if he is taking any of the drugs that may affect the growth. One of the common drugs that affect the growth is glucocorticoids. So you have to ask the patient if he is receiving chronic doses and large doses of glucocorticoid for treatment of any underlying disease, and the presence of irradiation. Finally, the family history, as we mentioned before, that constitutional and familial short stature are familial diseases, and they have a positive family history of short stature or delayed puberty of one of the family members or parents. And definitely you have to ask about any other diseases in the family to exclude genetic causes of short stature. So, as we mentioned before, here is some examples of the presentation or the diseases that are associated with short stature, including the following: the low birth weight, usually associated with a patient with small for gestational age. You have to ask if the patient is present with polyuria or any nephrotic and nephrotic signs and symptoms, to exclude chronic kidney diseases, chronic diarrhea, to exclude malabsorption or GIT problems. If the patient is presented with lethargy, constipation, weight gain, cold intolerance, you have to suspect hypothyroidism. As we mentioned, that hypothyroidism is one of the common causes, endocrine causes of short stature. Diet intake, it's very important to exclude malnutrition or undernutrition. Psychosocial history, to exclude psychosocial short stature, and definitely delayed puberty in cases of constitutional delay of growth and puberty. The body proportion, as we mentioned before, skeletal dysplasia is associated with disproportionate short stature. If you find pallor, the patient may suffer from CKD or chronic hemolytic anemias or iron deficiency anemia. Dysmorphism in case of genetic syndromes like Turner syndrome, as we mentioned before. Hypertension if the patient has chronic renal disorders. Some of these patient with growth hormone deficiency, especially the idiopathic or genetic growth hormone deficiency, may presented with some of the clinical features, facial features including frontal bossing, the breast nasal bridge, small penis and crowded teeth. hypothyroidism, as we mentioned before. By examination, you may find goiter. And finally, Cushing syndrome, the presence of juvenile Cushing syndrome or Cushing syndrome in the pediatric population is usually associated with short obese child, with the presence of other cardinal features of Cushing syndrome like stria, proximal myopathy, and psychiatric manifestations. This, by here we finished the first part of the lecture, which was the causes and history taking of a case of short stature. So the next part of the lecture will include the management including the examination and diagnosis and finally treatment. Examination of any patient with short stature includes three main pillars. First one is the assessment of the growth, which means the physical growth. The second is the mental growth, and finally the sexual growth or sexual assessment. The sexual assessment of the child will include assessment of the secondary sexual characters in both boys and girls to identify the pubertal stage of this child. We classify the pubertal stages into five main categories. These are the Tanner staging for pubertal development. And the assessment of Tanner stages depend mainly on, first, the external genitalia development in boys. This includes the testicular size, the scrotal development, the stretched penile length, and finally the pubic hair distribution. As you can see here, we classify the patient based on these criteria into five main categories, starting from 1, 2, which mean the infantile stages, and then more development, more enlargement will lead to more development of the pubertal stage, reaching the 5th stage, which is the adult stage. In females or girls, we assess the sexual assessment by breast development and by the pubic hair distribution. Again, we divide the pubertal stages into five main staging according to the pubic hair distribution and the breast development. It ranges from the infantile or pre-adolescent stage up to the adult stage. Next is the physical assessment. The physical assessment includes the measurement of the height. The measurement of the height of the child depends on the age. If the patient is less than 2 years, usually we measure the length in the supine position. As you can see here in the picture, the patient is lying down, supine position, and you measure the extended, the extension or the length from the head, the tip of the head, till the toes or the feet are placed. If your patient is more than 2 years of age, usually we measure the height in erect position, erect height. The patient is standing, and here we use what is called stadiometer. This is the stadiometer, which is a measuring scale against the wall, and the patient stands against the stadiometer. The head is in horizontal plane, as you can see here in the picture. The head is midway between flexion and extension. There are main 4 points touching the posterior wall: the occiput, the shoulders, the hips, and the heels. And finally, you take the measurement from the highest point of the head or the skull. Next, you should take the span, and the span means the distance between the tip of the middle finger on the one side to the tip of the middle finger on the other side. This is called the span. And then you took the upper segment and lower segment. The lower segment is the distance between the symphysis pubis of the child down to the floor, and you subtract the lower segment from the total height will give you the upper segment. Here we have some definitions regarding the growth assessment. First, the chronological age, which means the actual age of the child. This is the chronological age in years. The height age, that means this is the age at which the height of the child is at the 50th percentile, as we will see next in the growth chart, on the growth chart. The bone age, this means the skeletal maturation. This is an indicator for the skeletal maturation, and we get the bone age through X-ray imaging. The target mid-parental height, that means we calculate the mid-parental height, that means the father's height of the child plus the mother's height divided by 2, and we add 6.5 for boys, and we subtract 6.5 from this equation for girls, and this is the target mid-parental height for each child. Then we plot the results of the height and the mid-parental height on the growth chart, specific for each age and gender, to calculate what is called the family chart. The second important point regarding in assessment of the physical growth of the patient is the estimation of the body proportions. As we mentioned before, we take the height and the span, and we take also the lower segment and upper segment. Usually the ratio between the upper segment and the lower segment are equal, 1:1, and the ratio between the height and the span is equal, 1:1. So the patient having the ratio between upper and lower segment and height and span 1:1 is called proportionate. Otherwise, he is called as having disproportionate short stature. So proportion short stature, or causes of proportion short stature, that means that diseases or causes that involve both trunk and the lower extremities at the same degree. So the ratio is not affected, it's 1:1. While disproportionate short stature means that the disease is involved one limb more than the other. So the net result will be affection of one limb more than the other. So the patient may have increased ratio or decreased ratio. If the upper segment is more than the lower segment, this is increased ratio, and we see this in cases of short limb affection, in cases of achondroplasia or skeletal dysplasia. As we mentioned before, the patient has normal trunk, however short limbs, so the limbs are affected more than the trunk. The patient has increased ratio. On the other hand, some patients may have decreased ratio, where there is affection of the limbs of the trunk than the limbs, so the upper segment is to the lower segment is increased, and this happen in cases of short trunk in children or patients suffering from scoliosis or mucopolysaccharidosis, or in patient with Turner syndrome, because patient with Turner syndrome having short neck, so the trunk is affected, and hence the trunk is affected will be less than the upper the span, and the upper segment will affected more than the lower segment, leading to decreased ratio and the presence of disproportionate short stature. Again, as we mentioned before, we classify our patients into disproportionate short stature, that means increased ratio or decreased ratio in certain situations like achondroplasia or scoliosis or Turner syndrome. Otherwise, other causes of short stature are proportionate, or the ratio is from upper to lower are equal 1:1, is equal to 1:1. The next step, after taking the measurements of the child, you have to assess for the patient height and compare it with a normal population through plotting the height measurements on the appropriate growth chart. As we mentioned, for the growth chart we have two types, one for the boys, the blue color, and one for the girls in the pink color, and in each chart we have two axes. The horizontal axis presenting the age in years, the chronological age in years, and the vertical axis presenting here down the weight in kilograms, and the section above presenting the height in centimeters. So we have two curves the below curve for the weight and the above curve for the height, the same for the girls or the females. And here we have two lines for each curve. The lower line, this is the third percentile, the lower limit for the normal, and we have the upper line, this is the 97th percentile, this is the upper limit of the normal. And we have the midline, this is the 50th percentile. So the normal population lying here on the curve below the third and 97th percentile. If your child is below the third, this means that this child is suffering from short stature, as we mentioned in the definition, the first of the lecture. The next step is the calculation of the mid-parental height to exclude familial short stature. The mid-parental height is estimated through this equation. You calculate the mother's height in addition to the father's height divided by 2. In case of boys, you will add to this equation 6.5 centimeter. In case of females, you will subtract 6.5 centimeter. And the net result will present the age of this child as 20 years. So the figure of this equation will be plotted on the graph chart at the age of 20 to form what is called the family chart. So, and here is an example for a case of short stature. A female patient, 3 years, her height was 85 and weight 10 kilograms. So we pick the appropriate growth chart for her and we plot the height against the growth chart. So our patient is presented or lies below the third percentile. The next step is calculation of parental height. The father's height was 165, the mother's 155, and the mid-parental height equals to 153.5. We plot it against the growth chart in the 20 years plus or minus 10 to give the mid-parental height on this chart, and the patient is, after plotting of the mid-parental height on the growth chart and calculation of the family chart, patient is presented above the third percentile for her family, so this is a case of familial short stature. The height age, as we mentioned before, is the height of this child at the 50th percentile for their age. As you can see here, here is a girl, 5 years, her height 95 here, and the height age is, you go to the 50th percentile of this patient here, the 50th percentile, the age is 3, so the height age is 3. Finally, the bone age evaluation, as we mentioned before, the bone age is estimated through an X-ray imaging with the left wrist and left hand to be standardized, and we compare it with the normal population in the atlas. The most common widely used system is the Pile Atlas, a GP method. When you compare the left X-ray, left hand wrist radiograph is compared to the normal population according to the age and gender. And if the patient bone age is delayed, then the chronological age, so this is a case of pathological short stature. So finally, it's a very important to compare or to see the difference between, tabulate the difference between familial and constitutional short stature. As we mentioned before, parents through the following feature: the parent's stature is small in familial while average in constitutional. The puberty is normal in familial while delayed in constitutional. The birth size is normal in both. The growth is normal in both. The growth puberty is normal in familial while slow in constitutional. Bone age is normal in familial, delayed in constitutional. Timing of puberty usually normal in familial while it's delayed in constitutional. And finally, the adult height is short in the familial short stature. However, it is usually normal in cases of constitutional short stature. So finally, to summarize what we mentioned before as approach in case to a case of short stature, first you have to take the height of the child and compare it with the normal population on the growth chart, then you have to calculate the mid-parental height. You have to ask for X-ray for bone age evaluation. If the bone age is delayed, then height, age, and chronological age, this is a cause of pathological short stature. The next step is investigations. We have hormonal and non-hormonal investigations for assessment of growth of short stature, and finally specific imaging. The investigations will include routine investigation. This includes CBC, ESR, CRP, bone age as you mentioned before, urine and stool examination, renal function test, liver function test, fasting blood glucose to exclude chronic and malnutrition causes of short stature. Next, we have to exclude, as we mentioned, hypothyroidism by doing thyroid function test, karyotype if suspected case of genetic diseases, and finally, celiac serology for cases of malabsorption, and growth hormone stimulation test to diagnose cases of growth hormone deficiency. Regarding the growth hormone assessment, as you all know that growth hormone secretion usually occurs in irregular pulses, not in plateau. So it's very important not to depend on the baseline growth hormone for assessment of growth hormone dysfunction. You have to do what's called dynamic or provocative testing for assessment of growth hormone deficiency. The main stimulants of growth hormone, we have physiologic stimulants including the sleep, the nutrition, the exercise, the stress, and we have pharmacological stimulants of growth hormone, what is called the provocative agents, and these include insulin-induced hypoglycemia, glucagon test, L-DOPA, arginine, and clonidine. Usually, we go for growth hormone stimulation test by exercise and by clonidine test. The interpretation of the test results include in healthy patients, the growth hormone after stimulation should exceed 10 nanogram per ml. If it's less than 10 nanogram per ml, so this is a case of growth hormone deficiency. The next lab or hormone to be tested is IGF-1, which usually is low. So in patient with growth hormone deficiency, you will have low growth hormone, non-stimulated, and low IGF-1. The final step is the treatment or the management of short stature, and the management will be tailored depending on the original previous cause of short stature. So in cases of physiologic short stature, the management is just assurance and counseling for the parents. If the patient suffers from malnutrition or malabsorption or celiac disease, you should go for nutritional therapy. If the patient is suffering from chronic systemic disease, so it's very important to control a good treatment of the underlying medical condition with regular monitoring. In patients suffering from growth hormone deficiency, you should give growth hormone injections replacement therapy. And finally, patients with hypothyroidism will give them levothyroxine replacement therapy. Finally, we will talk briefly about the growth hormone therapy. Indications of growth hormone therapy are growth hormone deficiency, some of the genetic syndromes including Turner syndrome, Prader-Willi syndrome, CKD patients, and small for gestational age or are candidates for growth hormone therapy. The dose of somatropin or growth hormone injections depend on the weight, and usually you give the patient 23 to 39 microgram per kg per day, and it's given in the form of injections subcutaneously, subcutaneous injection every day or 6 to 7 times a week. After receiving treatment, you should follow up your patient and on the growth and assessment of growth velocity and bone age maturation. The patient response differs according to the cause of short stature. Usually for growth hormone deficiency, it may reach 8 to 11 centimeters, while it's less in other causes of short stature. When to stop the treatment? If the patient is attaining the final height or the patient growth velocity increases less than 50% from the baseline, which means that there is a poor response to your treatment, or the final height of the patient is less than 2 centimeters in the whole year, or if the patient approaching 14 years bone age in girls, 14 years or 16 years in boys, or there is problems with adherence. And thank you all for your attention. Wish you all good luck and thank you.